7, 6, 5, 4, 3, 2, 1.
Howdy, CROC Nation. Dr. Tommy and Ellie here with you with another amazing CROC podcast. Amazing because of me. Of course not. Amazing because of Angel. Okay, I'll give you that. But mostly more amazing because of you guys. Angel Santana, have faith, let it begin. How are you, my friend?
I'll tell you, it's a great way to spend a Memorial Day weekend. For everybody out there, it's a family weekend. But when you think about family, you think about the family show, the CROC Nation. And what better way to spend Memorial Day weekend with an amazing episode? How are you, Dr. E?
Oh, all is good here. Actually, I have a really interesting and nice podcast. I guess we should have done a Memorial Day theme, but I think after we did that Memorial Day theme with Ramon, I think nothing could ever top that.
Absolutely.
So we should, remember another time to put that in there. But today's episode was inspired by a story, a true story. And the reason why I know it was a true story because I was there. So unless you can consider me incompetent, which many people have accused me of, this is a true story. And it's going to be really, I hope, a story which will help many of our survivors and thrivers out there. So I'm sitting and I get called to see a patient. And this is a patient that I like very, very much. And she's still with us. And she's elderly. She's in her 90s. And she has a wonderful family. We took care of her husband. Just a terrific person. The patient and her family, admittedly, require a lot of information, which is great. That's what we do here on the CROC podcast. We try to make sure that you guys know what your rights are. You're allowed to ask as many questions as you want. It's not like Aladdin and the genie, where you only get 3 wishes. You get as many questions as you want. If your doctor doesn't have the time to answer those questions, then it's their responsibility to schedule a time when they do have the time to answer whatever questions you have. This particular patient had been through many, many different chemotherapies and many, many different radiation sessions. And she had received great palliation, meaning great pain control. The disease regressed. She went into a remission and she was doing very, very well. But unfortunately, that remission was starting to give up and her disease was progressing and she was having a lot of symptoms and she was admitted to the hospital. So the oncologist, who I actually really, really like, I really respect, I think this oncologist, I'm not going to reveal the gender of the oncologist, nor will I reveal the name, just made a mistake like we all do. And, I have discussed many of the words that have come out of my mouth that I regret and that caused people pain and suffering. And this was just his day. I shouldn't have revealed his gender. Anyway, I will. So it's a man, but he said something to the patient. So the patient and the family were very upset and they had been in the hospital. Their questions weren't being answered and they felt that they weren't getting anywhere with the discussion. So I got called into the room as sort of a backup and to help, manage the situation. And they pushed him and they pushed him and they pushed him until finally he just said, "What do you want? You're 90 years old. What do you want?" And it was at that moment that I said, wow, we need to talk about this. So today's episode is going to talk about ageism. And we're going to talk about what ageism means in oncology. We're going to talk about what are some of the ramifications of ageism. And I think it's going to be a really great podcast. And I think it's going to be very helpful. Angel, your thoughts?
Listen, I think this is something we can relate to. I mean, all of us are not getting any younger. And for those of you that are younger, don't blink. So this is important.
That's a really good line, actually. So I want to take a stab in the dark, Angel, and I'm going to predict something. So when I look at myself, even from as a kid, I had an old soul. I mean, I always was around my grandparents. I think my grandparents pretty much raised me. I was at their house more than I was at my own house. I liked to hang around with my mother and her friends, and when she would go visit them, I would like to rather than hang out with my friends, I'd like to go with her and go for an exciting adventure. And her friends were always so nice to me and so nice, just enjoyed that environment. It wasn't like, oh my God, I don't want to go out, go with my mother. My mom and I had, after my dad passed away, we would have monthly dates. She would take me out for dinner, take me to the movies or whatever. And then when I had gotten out of when I finished medical school and I was in my in between residencies, I even spent 6 months working in a nursing home. So I really felt that I have this connection with the elderly. Angel, my stab in the dark or my prediction is that you're the same way.
Yeah, I would agree.
Yeah, I mean, you're an old soul. I think you really, I could
Mhm.
see the way you treat your parents. I could see how respectful you are. And I think that's really important because we're going to get into this about actually the percentage of patients in oncology are generally elderly. So this is a big topic. This is really important. And it was really sparked by a colleague saying the wrong thing at the wrong time and really upsetting a family, understandably so. Also, there's age discrimination everywhere. It's not just in cancer patients. It's not just in our survivor thrivers. Yeah, I see it in my own, in my own house where my wife, when she was looking for a job, she's in her 60s. Um, she's so smart. She's so talented. She is so well educated. She has so many skills and gifts. Yet, it took her forever to find work. And, she should have gotten a job in 3 seconds. I also have experienced age discrimination in my own practice, where one of my associates is older than 70 years old. And I had some middle managers actually blatantly and overtly, say inappropriate things in meetings and actually caused some of the staff to feel very uncomfortable and made me feel very uncomfortable. And I had to actually protect my coworker, from an administrator. It was just horrible. And I would like to, give credit to the authors of the articles that we'll be discussing today in our discussion about ageism in oncology. And it's called, the article is called A Scoping Review of Ageism Towards Older Adults Cancer Care. The primary author is Kristen Haas, and it was published in the Journal of Geriatric Oncology in January of 2023. The PubMed index ID number is 36244-925, if anybody wants to look that up. And there was an editorial to the article in Lancet Oncology, volume 24, in April. And just to kind of go through, Angel, the what the paper was about. So it was what was called the meta-analysis, where the authors basically scoured the literature, came up with 133 papers, 44 of which were expert opinions, reviews, editorials, op-eds. 32 were quantitative studies, where people would actually look at the data, and 3 of them were qualitative data that would look at interviews. And we've done qualitative research on this podcast. Actually, our last podcast was qualitative. So before we start, Angel, let's define what ageism is. In 2018, the World Health Organization kicked off a global campaign to combat ageism. And ageism is defined as stereotyping, being prejudiced toward or discriminating against an individual based on age. So it's very simple. The elderly not being taken seriously, the elderly being taken advantage of, the elderly being biased against, as we discussed. And the effects of ageism, as you can imagine, Angel, are quantum. I mean, they're very important and very profound. Number one, it could result in negative health consequences. Number two, it can limit access to appropriate health care. Number three, it creates a paradox because, as I mentioned at the beginning of the podcast, the preponderance of cancer is in older individuals. Yet these older individuals are not getting the best care. And these individuals, these populations, are actually increasing exponentially, meaning that as science and technology and healthcare become more sophisticated, we're living, longer. We're getting older and requiring healthcare, and our oncology population is likewise getting older, but they're not getting access to the same healthcare that the younger cancer patients are getting. It's also creating a barrier to appropriate medical care, social resources, and technology. And lastly, it's actually affecting clinical decision making, which is causing poor outcomes. So the paper breaks things down into four categories or themes to oncologic ageism. One is heterogeneity of the cohort and the geriatric assessment, and we'll get into the meaning of that. Number two is a significant lack of access to clinical trials. Number three is a cancer screening bias. And number four is undertreatment. So let's start with heterogeneity. So there was a study done looking at, and it was a lot of patients. It was over 600 patients. And it broke patients down into nursing home patients and into community patients, all with cancer. And what they found is the patients that were in nursing homes got more care than patients that were in the community. I have a personal perspective about this, and I talk to my patients about this all the time. It's the perspective of biological age versus chronological age. And I'm going to tell you a little story. So prostate cancer in men, especially low risk or intermediate risk prostate cancer, is a slow growing tumor. When a patient is being seen by me and I look at the charts the first thing in the morning so I'm prepared when they come in, and I see a patient who's 77 years old, 84 years old, 85 years old, my first question is, why is this patient coming to see me with prostate cancer? Really, do we need to treat this person? We can actually hurt them, but more than we can help them, because they're probably going to live another 5 years and not die of their prostate cancer. So I could kind of see in my own mind where ageism can begin. So my first thing that I do is when I walk in a room, I assess a patient's age. So I look at how old they really are. Then I look at their medical chart and I look at high blood pressure, if they've had any heart attacks, open heart surgery, stents, if they have diabetes, if they have vascular disease. And then I just look at them. I just eyeball them. And I say, really, are you really 77 years old? Man, you look like you're 55 years old. You look like you're 62 years old. And I really try to assign not their chronological age, because we know what their chronological age is. They were born in 47, they were born in 42, they were born in 38. I look at what I believe their biological age is. So someone who's 72, 77 might have that as their chronological age, but their biological age could be 65, 62, 58. I took care of a patient the other day who was in his high 70s, but really lifting weights 3 times a week, walking, playing golf, doing everything that he wants. And he actually has no comorbidities. A comorbidity means other medical problems other than their cancer. So I basically allocated a biological age to him of low 60. So when he came in to see me about prostate cancer, I had absolutely no problem discussing all different treatments for prostate cancer. So that's my theory of heterogeneity in the perspective of biological versus chronological age. Let's switch and move to significant lack of access to clinical trials. People that are 65 years or older constitutes 56% of the disease population in most clinical trials, but they're only represented by 40% in those studies. So even though there's 56% of them make up that cohort of patients, that population of patients in that study, only 40% are really being accrued to those studies. And a more shocking number is that 80-year-old patients or older, they comprise 16% of these studies, but they're only represented by 4% of the patients. So there's a huge paradox here. Going down the line to cancer screening bias, a patient goes to their primary care doctor. And let's take that patient who's lifting weights and playing golf and doing all these cool things, who doesn't have any comorbidities, and they may be excluded from getting a PSA. Their doctors may not even test them, or just say they won't get a colonoscopy, which would catch an early colorectal cancer, or women are not getting their mammograms, even if they feel lumps, because they're being discriminated against. This is ageism in screening, and it causes a bias. It's the way their doctors are looking at them. And last but not least, undertreatment. So doctors see someone who's in their 70s, whatever their comorbidities are, the treatments, and we've pretty much talked about this on every podcast over the last 4 years. Cancer treatments can be very toxic. We know that. And I'm going to say I'm part of this process. I'm part of this broken system. We have a fear of hurting people. We have a fear of giving them side effects. So we bias ourselves to try to limit what treatments are being given to our patients who are elderly. And that's wrong. Every one of those things that I just mentioned is wrong. And Angel, this creates a vicious cycle. So older patients, they're excluded from studies. And this is really a very striking statement. They are excluded from studies without any evaluation or documentation of their performance status, without any deep dive investigations into their other medical illnesses, their comorbidities. This causes an underrepresentation in these clinical trials of patients that are older, which then takes us to a screening bias. Patients aren't even being tested to find out if they have cancer. That's leading to undertreatment. This undertreatment is leading to a paucity of data, meaning that there's not enough patients that are being treated that could be studied to see how many are really benefiting from these treatments, or how many of them are actually being harmed from these treatments. And without this data, we can't then drive better medical care to our patients, which then feeds into this healthcare disparity and these inequities that our elderly cancer thrivers are receiving. And this ultimately leads to poor outcomes. And what we have, and this is the saddest part of all, and I've even written this in red pen to remind me of how important this is, we have developed in the literature mechanisms, research tools, and algorithms of how we can help prevent or eliminate ageism in our elderly cancer patients. But guess what? They are being ignored and they are not being used. And lastly, there's a recommendation to begin indoctrinating doctors even before they're doctors in medical school, in their first year of medical school, and starting to get them sensitized to the fact that they're going to be taking care of elderly patients, and not to perform this bias, or not to perform this ageism in the care of their patients. And this, ignoring, or this, just not using all these great tools, then brings us back to that circle of older patients being excluded from studies, et cetera, et cetera. So it's this large vicious cycle. But Angel, the way we work here, we may not be able to give you an answer on this podcast about how we can help or prevent ageism, but I do have a few suggestions. So number one, we always try to have our cancer thrivers know what their rights are. And you have the right to be treated the same as anyone else, even despite your age. Now, if you do have issues or comorbidities or performance status issues, that's okay, but it's definitely, you are definitely allowed to ask these questions and be given answers in a very respectful way. Number two, know who your advocates are. So there are federal advocates for age discrimination. There's state advocates for age discrimination. There's county advocates for age discrimination. And what they recommend you do is to document these incidents with dates, with times, with witnesses, include your comments. I see patients come in all the time with their cell phones, their smartphones. They're taping their consultations with me. I have no problem with that. I have nothing to hide. And, it actually makes me even be more on point if possible. Please use your cell phones, record these interactions with people that are discriminating against, and use the Iannelli model. We've been using this model on this podcast since day one. Ask your doctor, what's your biological age? We know how old we are. And if you don't know how old you are, then don't worry about it, because you probably shouldn't get the treatment anyway, right? But know what your biological age is. You might be 77, but really biologically, you might be 56. Ask your doctor what he or she thinks your chances are of living 5 years or 10 years or longer. Let's find out, because nobody wants you guys to get hurt. Me, number one, online. Don't want you to get unnecessary treatments, but I do want you to get treatments you need and that you can sustain and get through. Ask your doctor to formally record your performance status. So we have all of these different performance status metrics, or these performance status tools, or these nomograms, where you have to say, all right, patient can take care of their acute, their daily needs. They cook for themselves, they clean themselves, they could shower, they're independent, they could walk around the house, they could walk a mile without getting winded. We have there's so many of them. Make your doctor use these mechanisms so they can actually know if they're not going to be offering you treatments that you think you should have from some of the latest and greatest, drugs or molecular targeting agents or immunotherapy. Let them prove to you that you're not a candidate for it. And make sure that they fastidiously define the degree of each comorbidity. So you walk into a room and the doctor gives you this big form to fill out. It's probably multiple pages. Have you ever had a heart attack? Have you ever had a stroke? Have you ever had surgery? And say the answer is yes, that you had a heart attack, when you were 55 years old. Okay. You have 2 stents. That doesn't mean that you should be excluded from the trial or be excluded from treatment. It just means that you need to go to your cardiologist and have them absolutely work you up to the nines to find out exactly if that issue is still operative in your world. Because again, we don't want to hurt you. We don't want to do the wrong thing, but you deserve to have all of these steps completed so you are not discriminated against. And then I also want to, last but not least, want you to clearly identify what your healthcare goals are, not just for this minute, but for the year, for 2 years, for 5 years, or even longer. What is it that you want your golden age to be in your cancer journey, in your journey as a survivor thriver? Do you want really aggressive treatment? Do you want to try to live and push the envelope for as long as you want? Or do you prefer just to be comfortable and live a very high quality of life? But I can't answer that for you guys. Angel can't answer that. You guys have to answer that. And no one really takes the time to think about these things. And they seem so self-evident, but they're, on our thriver side, they really need to be pushed to make these thought processes and these decisions. You need to clearly identify to your doctor your healthcare wishes. You need to formally and legally document your healthcare advance directives and your proxies. and share this information and your wishes with your family, with your proxies, with your attorney. Force, and you shouldn't have to do this, but I'm going to tell you, force your physician to discuss the decisions that are made about your health, made about your health care, made about your treatments, and make sure that you feel that you're not an agent, or you're not a victim, I should say, of discrimination or of ageism. And lastly, I'm going to end the podcast with the same story that we started with. So I am in the room with this lovely woman and her lovely family, and they're a lot. I'm not going to tell you they're not, but they have the right to be a lot, right? And the patient had received many effective treatments. The patient had received several rounds of radiation, some of which were retreatments, which again, there's only so much you can do and so much you can give. This family and this patient clearly had expectations which were not realistic. But what was missing was that transparent discussion that was never done, and the wording that was used. Like finally, the physician blurting out, "Lady, you're 90 freaking years old. What do you want? What do you want me to do?" And that set everything back, to a really bad place. And had the wording, which was destructive, the wording that destroyed an opportunity, Angel, an opportunity for appropriate education and realistic goal settings. And I really want to thank this family for this lesson, which inspired this podcast. And I hope it will be helpful to all of you out there. Some of you, it may be, right now operative in your life because you might be 65 years old or older, or you might be a young survivor thriver who will one day be 65 or 70 or 72 or 77 or 82. So Angel, your thoughts?
It's interesting, as I sit here, and starting from the very beginning of what we talked about my generation, I remember, many times as I had conversations with my elders, one person I remember saying to me, don't regret growing older. It's a privilege denied to many.
Yep.
And it's a great quote. And I remember that when we were talking about it. But the most important thing is, as we've gotten older, as you get older, as you're at that age, we must remember that it's not that we have more patience as we get older. It's just that we try to care about all the pointless drama. Yeah. And as we get older, you will understand that the more and more that it's not about what you look like or what you own, it's all about the person that you've become.
Now, Angel, have you ever, noticed any discrimination toward your parents in healthcare?
No, but myself, even at a younger age, and when in my 20s, when I was in sales, I remember getting job opportunities because I didn't have a college degree, but I did have experience, and they wanted to pay me, less because I was younger. Now, the point I'm making is you flip that 20 years later, I came in at 40 something years old, back in the same position, and I was treated a lot different, more like my ways were out of touch. My style was beyond measurable what we are today, but yet my team did exceptionally well, and the others, felt like dealing it with fear. So there's, I felt it in different ways.
So Angel, I always appreciate your comments, and they're always so wise for such a young boy. All kidding aside, I just wanted to take a minute to end this podcast by my pep talk, especially to my to our survivor thrivers who are 65 years and older. When you walk into a doctor's office and you feel that you're not getting taken seriously because of your age, or if you feel that you're not getting the treatment that you deserve, and if you really feel in your heart that it is your desire to live a longer life and to enjoy living into your 80s or even longer, and you feel that you can live 5 years or 10 years, I want you to make sure that your doctors can either prove to you that you can, or prove to you that you can't. I always tell you guys, and Angel does the same, that you deserve respect and you deserve to be treated with nothing but the highest level of regard. You should be treated as a absolute, you should be the most important person in the room, and your doctor should be speaking to you and giving you information and educating you. If you feel you're not receiving that, then you are a victim of ageism in oncology. If you feel that there are clinical trials that are being withheld from you, you need to discuss this with your doctor. If you feel there are treatments that are being held from you because you're too old, then you're experiencing discrimination. If you feel that you really can receive these treatments and manage these toxic side effects, you need to have an open conversation with your doctor. And I really want you guys to know you are the majority in cancer care. People that are 65 years and older predominate in cancer. And it's going to get more and more each year. So I want you guys to unite, and I want you to band together, talk to your representation in politics, in Washington, or even your state level people that represent you. And please, please do not accept anything less than what you deserve. Angel Santana and Have Faith, Let It Begin, to the rest of the board of directors, I thank you for your generosity of spirit and for giving your talents to these group of survivor thrivers who deserve nothing but the best. And closing out, as we close out each podcast, we do it with our expression, wishing you all a long, healthy, happy, and cancer-free life. God bless you. God be with you. Peace.